folks, to our colleagues in Hawaii and perhaps even in Guam joining us today. I'm Jill Holt with Mountain Pacific, and this is the 8th of a 13-week series of It's Worth a Shot. We're so happy that you've joined us today. We have something kind of cool on the radar for you this week. But before we get started, let's take a step back and cover some of our basic information. If you could advance the slide, Mary. Just a reminder that if you think of anything along the way that you'd like to see us cover during this series, we'd be happy to take a look at that. Just enter your ideas into the chat box. And just as a reminder, we're meeting every Wednesday at 2:30 for a quick half hour, and that's scheduled to proceed through April 13th of this year. Next slide, please. Each week, whenever we have questions presented during the interactive portion of our series, we like to just go back and recap those questions. And also we send these out in the FAQ that we generate each week. So it's kind of a live document. Each week we add the new questions and answers to that document. So hopefully you're finding that as a helpful resource. So for last week, the question was, is the and you'll recall that we had a presenter from the Alaska Department of Health, who's a lead surveyor in Alaska, Matthew Thomas. And so the question was, is the staff vaccine matrix a required document? And the response is that the use of the matrix document is optional. If the facility already has its own tracking sheet, for example, an Excel spreadsheet, that is certainly sufficient to provide the surveyors. And then the follow-up question to that was, when using the staff vaccine matrix, is it only for the facility staff, or do contractors / consultants need to be added in? And the response is yes, the matrix does include staff that are under contract or MOU, Memorandum of Understanding agreements. So for example, if someone comes in to provide physical therapy from another facility and they perform those cares in your facility, they are considered a contract under agreement and would have to be part of your listing. So you would want to make sure that you provide that to the surveyors so that they can gather their sample and decide who they'll be interviewing and take a look at that. So any questions about that before we move on? Okay, well, so this week we have for our clinical portion, we have Dr. Kunzweiler. He'll be presenting on vaccine hesitancy and the history of vaccines, but he'll be the second part of our presentation. So the first part of our presentation will be what we consider a partner spotlight. And this will feature some best practice sharing from one of our colleagues in Wyoming, Sabrina Gines. She's with Powell Valley Healthcare, and she's available to share some of the things that they've done to increase and enhance their resident booster uptake. Sabrina's the infection preventionist and quality nurse for their organization. So Sabrina, are you available? Do you hear me okay?
Yep, I hear you.
Okay, take it away.
Okay. All right. So I guess go to the next slide. So Jill had asked us to talk about our resident booster rates for our facility. So we had 59 residents in our facility. We've only had 4 that have refused the initial COVID vaccination series, and we've had 1 refuse the booster since then. So we've had 93% of our residents vaccinated, with 98% of them that are boosted. We have 2 that are within their 5 months radius. So after May and June, we will have all of them boosted. And so, okay, go ahead, next slide. So we have worked with our infection control for the hospital. So we have the hospital and the care center, and we work together with getting our COVID vaccinations. So we have, they were providing weekly COVID vaccination clinics, so that we can get all of our residents vaccinated. So she would have the vaccinations, and then we would just let her know which ones we would need so that we can bring them over to the care center and have vaccinated. So she has recently changed it to every 3 weeks now with our clinic, with the COVID vaccination clinic, just because the decreased number of residents that need it and the decreased number of staff that need it, because we are getting closer to having everybody vaccinated. And during this time, I would call her and say, I need, so many doses so that we could get our residents. And then with each clinic, we would go and offer the residents that have not had their vaccinations or their boosters. We'd offer them again. So our pharmacy does a really good job of reviewing the medications of our residents, and they look at the vaccinations. So if the pharmacy notices that they are within their time frame to get their vaccinations, they will send us a note saying, this person is up for her booster or their booster, and we'll, so that we can work with the hospital infection prevention and get those moved on. We look at new admissions. We look at their vaccination status prior to coming into the care center. And then when we have a potential resident, I will go on and make sure that they have their vaccination. And if not, we coordinate those to get their booster once they're here. Next slide. We do a lot of education with the family, the staff, the residents about the benefits of the boosters. A lot of ours came during the flu season when we were doing our flu vaccination. We would talk to the family and the residents at the time we were doing their flu vaccinations to see if they wanted their booster. And a lot of them at that time agreed to have their booster while we were doing the flu vaccination, because we had to talk to everybody about their flu. So we just incorporated the booster vaccination into it. And then again, with each clinic, vaccination clinic, we re-educate the residents that have either previously declined, and then and re-offer it to them. And then the ones that have refused the initial series, we re-offer them to. So next slide. So the ongoing collaboration that we work with, I continue to work with our hospital IP. So she lets me know when she's doing her clinic so that we can, again, offer. The interdisciplinary team, we do a pre-admission assessment, a new resident profile, looking at their vaccinations. If they've had their initial series, then we work on getting their boosters when they get here. Making sure the residents are vaccinated. If not, we talk to the provider and the residents to make sure that they get their vaccination upon admission if they're eligible. Are going on the monthly pharmacy reviews. And then our physicians are really great about helping with the education with the family. If we have somebody that is hesitant, or they're really good about stepping in and helping with that education from the physician's point of view. Okay, next slide. That's it. All right, thank you.
Thanks, Sabrina. That was awesome. Thank you. Does anybody have any questions for Sabrina? Okay.
Yes, quick question. Do you have a form that you use on that admission to screen folks on their immunizations that you can share?
Yeah, it's just a resident profile, so it's kind of like a getting to know you form. We do nursing assessments where they go in and they talk with the family, they go to the house, do their assessment. And then on there's just a portion of their just saying, are you vaccinated? Do you have your flu, pneumonia? And and your COVID vaccination. And it's just a little form on there. And then also I work with our social services who coordinates the admissions, and I get their name and I can look them up on the state registry site also, so that we have those prior to moving in.
Sabrina, you did great with the residents. I'm wondering how you did with staff. That seems to be the sticking point for everybody.
Staff is a little tricky. I don't have my numbers right now. I can look them up for you, but staff, we have, I'm not for sure. I'd have to look it up for you.
What have been some of the successes that folks have used for getting getting your staff to agree to be boosted? Is there anything that you've done, like a best practice that anybody else would like to share that you found to be effective? I guess my other question would be, what are the barriers? What are staff saying that one of the reasons they prefer not to be boosted? Has anybody shared any examples of that with you?
This is Jennifer in Petersburg, and we have, and prior to the mandate, 100% vaccination rate, and we have so far just 2 staff who are not boosted. But pretty much what they've said is they came to us vaccinated, but they had to be vaccinated for their previous job. And so that's why they did the initial series, and they're not interested in a booster at this time. We're hoping that, you know, we can help move that perception for them, because we do really feel like we should have 100% up-to-date coverage and people who work in long-term care. So I'm hopeful that that will change, but overall, we really haven't had much of an issue. But I think that is one thing, is they'll do what they have to do to have a job, and that's it.
Sure. Okay, thank you for that feedback. I see Lori posted in chat that for staff, one at a time answering their concerns. Also making the vaccine convenient and we've been offering clinics at our long-term cares. Our rates are far above both state and national rates. And then I think some of the barriers Cynthia is responding to are that folks don't appreciate government interference, don't think it works anyway, and do not trust the science behind it. Thank you for those comments. I don't think there's anything that we learned as far as what folks are saying. People have been pretty consistent about their reasons for being concerned, in spite of countering those concerns. That seems to be a pretty consistent verbiage from what I'm hearing too. All right. Well, Dr. Kunzweiler, I love your title on your PowerPoint, COVID-19 news to use and too good to refuse.
Yeah, actually, this is a talk that I gave to the Montana Healthcare Association, which is our long-term care association, and so some of this is a little bit outdated. I gave it, let's see, last fall, but it's still valid. So, could I have the first slide, please? So, if you're going to try and convince, oh, I lost everything. I lost my picture.
We can still see and hear you.
Okay, all right. Well, it suddenly popped back. I love this. If you're going to try and convince people to get a vaccination, I think you have to start with knowing something about the history of vaccination and how they're made and their safety and that sort of thing. And I have a very soft spot in my heart for vaccination, because when I was a little boy many years ago, polio was striking, especially children. all through the United States. There was an epidemic of polio. And I can remember particularly my mother being scared to death that I was going to get polio. And she didn't even want me to go outside and play. In 1955, I was 4 years old, and the Salk polio vaccine was released. And every kid in the tiny little town that I grew up in got drugged down to the town center, and we all got jabbed with a needle. And back then, the needles were not disposable. They were sharpened, supposedly in between uses, and sterilized. But it was rather a horrifying experience for the children. The parents were all crying tears of joy, and the children were all crying because they'd been stabbed with a dull needle. But at any rate, that was amazing when the polio vaccine came out. It took away that worry. People have been doing what we think of as real vaccination since the late 1700s. Edward Jenner was inoculating people with a cowpox virus, and it protected them against smallpox. Cowpox is related to smallpox, and the viruses are similar enough that worked as a vaccination. And then in 1885, Louis Pasteur took rabies virus and killed it and injected that, and found that by doing that, he could make people immune to rabies, which also became a treatment. Since rabies is a very slow growing virus, if you started getting vaccinated as soon as you were bitten by it, you would develop antibodies before the virus could spread from the bite wound to your vital organs. So we've been doing this for a long, long time. In the 1930s, some of the big killers were cholera, diphtheria, typhoid, and vaccines were invented for those. My grandmother lost her second child to diphtheria at age 2. I think that people today just don't realize how devastating some of these diseases were and how effective vaccine was at removing them. 1963, measles and rubella. Now, as a child, I had measles, and the only thing they did for you back then is they quarantined you in your house. And I can remember being stuck in my bedroom, and they thought that if you were overstimulated, it would cause you to have seizures. And so the room had to be darkened. And I can remember I spent about a week in my bedroom with the curtains closed, pining to get outside. But measles is almost unheard of now in America, and it's because of immunization. Next slide. Influenza vaccine started in 1968. In 1972, we stopped immunizing for smallpox. I got immunized for smallpox as a kid, and then I got it twice more, courtesy of Uncle Sam when I was in the service. But the smallpox vaccine worked so well that it was discontinued in 1972. And the mortality rate of smallpox in otherwise healthy people was about 30%. So if you got smallpox, you had about a 1 in 3 chance of dying from it. Terrible disease. And that brings up the topic then of, well, these new vaccines, they're manipulating RNA and DNA, and this is something new, and it's just kind of crazy, and they don't really understand what they're doing. Actually, for about 20 years, people have known about messenger RNA and been developing both chemotherapeutic drugs to treat various cancers with it, and they have been developing other vaccines. 20 years ago, they developed a vaccine for Ebola. We haven't had Ebola on this continent, and in Africa, it's been difficult to distribute, and the Ebola outbreaks have been so sporadic that it hasn't been cost effective to do mass vaccinations, but a messenger RNA vaccine for Ebola was developed, and it works, and it's safe. They also developed one for Zika. You may remember 5-6 years ago, there was a lot of information about Zika, which was apparently a new virus that evolved. It was in South America and the Caribbean, and it was causing malformations of infants, especially poor development of their brain. We don't know what happened. The Zika virus just sort of vanished on its own, so the vaccine really hasn't been used much, but it was developed probably 6, 7 years ago, and it worked and it was safe. Next slide. So the other thing I wanted to talk about a little bit were the other things that we have available to fight off pandemics like COVID. In 1867, Joseph Lister proposed the germ theory of disease. That before that time, people thought, well, it's because you're a bad person, or it's because you live somewhere where the air is not pure, or or it's the wrath of God, or something else was causing you to get these horrible diseases. And Lister said, no, there's these little things that you can only see under a microscope that are causing it. And of course, he turned out to be right. Prior to that time, people were doing surgeries with their bare hands, and masks, surgical masks, were not used. And so no matter how good the surgeon was, he was always contaminating the wound of his patients. And many people survived the surgery only to die of infection that was spread from the mouth and the hands of their surgeon. By the 1920s, pretty much all of medicine had accepted the fact that sterile gloves and masks were important in taking care of patients. And ever since then, they've been used. And there are study after study after study showing that masks work. And the last winter, 2020, 2021, in Montana, we had almost zero influenza. And it's because people were socially distancing, they were wearing masks, and they were washing their hands frequently. Next slide. So when people talk about why they don't want to get vaccinated, one thing you hear a lot is, well, these are just too new. They don't know what they're doing with them. And as I said, it's been 20 years plus now that they've been working with messenger RNA type vaccines, and they know what they're doing. The other thing you will hear is that it's just not safe. They've done this so fast, it's not safe. Well, all of these vaccines were tested in the same way that every other vaccine has been tested. The measles vaccine, polio vaccine, smallpox vaccine, they're all tested in the same way. The thing they did that was different was because of today's technology, they were able to sequence the genome, that is the RNA of the virus, very, very quickly. In a matter of weeks, they were able to sequence the full genome. By doing that, they were able to target the part of the virus that they wanted to make a vaccine to, and they picked some of the protein that coats the outside of the virus. And that, as I said, only took a few weeks to figure out what part they wanted to attack. And then they started developing the vaccine. Normally what you would do is you would develop a small quantity of the vaccine. You would give it to about 50 people to see if there were any immediate reaction. If that went well, then you would give it to about 1,000 people to look to see if there were some other sort of late developing or hidden reactions. You'd watch them for a year or so. If that went well, then you would give it to a large number of people, maybe 20, 30,000. And then you would take another 20 or 30,000 people that were matched for age and sex and comorbidities, and you would not vaccinate them. And then you would watch those two groups for a year and then compare them to each other to see if the vaccine was effective. In other words, if the people who got vaccinated did not get sick and the ones that you did not vaccinate did get sick. Well, they tested this in the same way for these new vaccines, but they did these tests all at the same time. And at the same time, they began developing or producing the vaccine in big quantities. Now, that was a big risk, because if it had turned out that the vaccine either was unsafe or did not work, they would have sunk a lot of money into the testing and a lot of money into the production of the vaccine, and they wouldn't have been able to use it. But they were pretty certain, because of their experience developing vaccines for Ebola and Zika and some of these others, they were pretty certain that this was going to work, and they were quite certain that it was going to be safe. So these companies like Pfizer and Moderna, Johnson & Johnson used an older technology. They used a killed virus sort of technology, but they all did the same thing. They all started testing right away and producing right away. That's how, within less than a year, it took about 9 to 10 months from the time these companies started to have vaccines that were available and were tested. Before then, it would often take 3, 4, 5 years in order to figure out how you're going to do it, produce a little bit of vaccine, start the testing, and then after you've done all the testing, then start producing it. I think it took 6 years to come up with the mumps vaccine. So this was a kind of condensing all of the same steps and doing them simultaneously instead of in sequence. Next slide. But it worked. So how do vaccines work? What is this really? It sort of sounds like black magic or, some kind of quackery. But it's very clever. It's one of the triumphs of Western medicine. All a vaccine does is it tricks your immune system, your own immune system, into forming antibodies that will attack a germ before it actually shows up in your body. And there's a variety of ways to do this. Pasteur with rabies started with the rabies virus and he killed it. And he found that if you injected the killed virus, your body would still form antibodies to it. The virus couldn't hurt you because it was already dead, but you would form antibodies to it. So then when the actual live virus showed up, your body would already know how to fight it. You can do it by using other viruses that are similar to the pathogen you want to get rid of, but they are alive. And there are some of the polio vaccines used live virus. There are others that used live virus, but they weren't the same virus that caused disease. They just looked like the same. And so your body would recognize the real germ when it came along. And then some, like these newer ones, take a part of the virus or the bacteria, whatever it is, and they present that to your body's immune system so that you form antibodies to that part of it. It can't hurt you because it's just a little bit of protein. It's not the whole virus or the whole bacteria, just a little bit of it, but it's enough that your body can form an antibody that will then help you fight off the real thing when it shows up. And that's how Moderna and the Pfizer vaccines work. Next slide. So it's just tricking your body into fighting a germ before it actually gets there. And through trial and error and testing, we learned that a lot of the time, these vaccines need a little boost. Measles, mumps, and rubella, for instance, takes 3 to 4 shots before you develop full immunity. Chickenpox vaccine takes a couple of shots. The new shingles vaccine takes a couple of shots before your body is really completely woken up and ready to go when the real thing shows up. So the fact that you have to have a booster is not unusual. Now, with things like influenza, the influenza virus is very clever in that the virus changes itself pretty readily. And because of that, every year we have to have a new booster. And what we're doing there is trying to prevent the particular strain of influenza that's going to be prevalent in that next year. It's a little bit of a guessing system. People surveil the entire world and they look to see what are the strains that are most prevalent in the Southern Hemisphere during the summer. And then that's what they use to make up the vaccine to give people in the Northern Hemisphere their shot in the fall or the early winter. Some years their prediction is very accurate. Some years the virus, fakes them out and goes left when they thought it was going to go right, and it doesn't work all that well. But that's what they're doing with that. And something like that may happen with COVID. It's much like influenza in that it can change very quickly. And so it may be that we're going to wind up having to have an annual booster against the prevalent strains of COVID. Right now, it's too soon to know. Next slide. Are they safe? Yes, these are very, very safe vaccines. Significant reactions are well under 1% of the people who have been vaccinated. And by now, tens of millions of people worldwide have been vaccinated. There is a certain percentage with any vaccine of people who are going to have trouble. We're going to have allergic reactions or some other odd reaction. There's just no way to get around that. But it's also true of medication. If you develop any medication, a certain percentage of people are going to have trouble with that medication. With these viruses, the problems are really vanishingly rare. Unfortunately, with the way news spreads today and disinformation spreads, it gets a lot of publicity. And so if you are somebody who watches 24-hour news a lot, or you spend a lot of time on the internet looking at news, you're going to get a very distorted image. And what they are going to be putting in your face are the very, very small number of people who actually have had a problem with it, or a lot of people who think that they had a problem with it, but when you investigate it, turns out not to be so. Next slide. So when we look at who had to be hospitalized, who had to wind up on a ventilator, and who died of COVID, the numbers are, I mean, they're pretty impressive. 99% of people who wound up in the hospital, 99% of people who died were unvaccinated. And that, my friends, is Mother Nature telling you that the vaccines work. That's just all that you can draw from that. Next slide. So, vaccine hesitancy, some of the arguments that I have heard and have heard others talking about. One of the first is, this is intrusive. It's the government telling me what I have to do. It's my body. It's my right not to be vaccinated. And I agree with that. It is your right. And if you were a hermit and never came in contact with anyone else, I would say, good on you. Go ahead and take your chances. But like every right, we also have responsibilities. A long time ago, I took my first driver's test and I passed, and I earned the right to drive a car. But that also gave me the responsibility to obey traffic laws. I have to stop at a stoplight. I have to stop at a stop sign. I have to follow the speed limit. I have a right to drive, but I don't have a right to drive anywhere in any way I want, because I have to protect the general public. I have to follow the rules so that I don't kill somebody else or kill myself. And this is very similar. In America, I have a right to smoke cigarettes if I want to. It's America. You're allowed to be as dumb as you want to be. And, but I don't have a right to do it anywhere and anytime I please. I can't do it in a restaurant now, at least not in Montana. I can't do it in the general public, because that action of mine can have effects on other people who don't want secondhand smoke, and the illnesses that can cause. So we have responsibilities. We have rights, but we also have responsibilities. And I think, especially if you're trying to convince your staff, if you want to be in a healthcare profession, I think the onus is on you to not make the people that you are trying to help sicker. So if I operate on somebody, I have to wear a mask and sterile gloves. I have to follow good sterile procedure. If I'm going to be working in the hospital around pregnant women, I have to be immunized against measles. Or if you're an old guy like me and had measles, you have to have evidence that you are immune to it, because spreading measles to a pregnant woman can affect the fetus. So rights, I agree with rights. This is a free country, but rights are not absolute, and they are not 100%. Every right has a responsibility. The other argument you hear is that the vaccines are unsafe. And I think, as I talked about, if you get your information from the internet, it's going to seem like that. It's going to seem like we're always on the verge of some sort of catastrophe. And a lot of these sites will have physicians or somebody who seems to have credibility standing behind them, and it can be difficult to tell, what is fact and what is fiction. Almost everybody has an agenda, it seems like these days, and it's easy for them to get on the internet and spread their view. But by now, as I said, tens of millions of people have been vaccinated, and the problems with the vaccine have been very, very minute. These are some of the safest vaccines that have ever been developed. And as I said, vaccines have been been being used for over 150 years now at this time. I've heard religious arguments that my religion tells me not to be vaccinated. I've done a fairly extensive review of all of the world's major religions, and I haven't found any of them that prohibit vaccine or that say that vaccines are somehow going against the will of God. Now, there may be people who that is their personal view of religion, but there's no organized religion that is saying you cannot get vaccines. I've seen on the internet that aborted fetuses were used to develop these vaccines, and that is absolutely 100% untrue. What the tiniest little kernel of truth is that umbilical cords in the 1970s, not from aborted fetuses, but umbilical cords donated by mothers in Sweden after their babies were safely delivered, were cultured and grown in culture and used to test medications to see if in vitro, that is in a petri dish, did those medications have any ill effects on human cells? And many common medicines, ibuprofen for one, were tested that way. And some of these vaccines, some of the basic components of these vaccines have been tested that way. But that is not anything to do with aborted fetuses. That's just not true. And it's even been vetted by major religions all around the world, and everybody agrees that everybody who knows what's going on agrees that that's not true. My own personal view is God gave us these big brains that we have to lug around every day, and he gave them to us so that we could use them to help each other, to help protect ourselves and to help each other. And development of vaccinations is one of the ways we have done that. And I'm not getting vaccinated solely for myself. I'm not doing it to protect myself. I'm doing it to protect my community. I was born in 1951. I'm 71 years old, but I'm pretty healthy. I'm not really too worried about getting COVID and dying from it. But I don't want to be the person who spreads it to somebody whose immune system is compromised, who might get very, very sick or even die from it. And I can tell you that the more I read about the long haul COVID, the more I'm really glad I'm vaccinated and boosted. I really don't want this stuff. It's pretty nasty. Next slide. There were a lot of people who worried about pregnancy and getting the vaccine. And I understand that. When you are pregnant, you're kind of hypersensitized to everything. People who drink alcohol stop drinking alcohol during the pregnancy. Those who smoke often give up smoking during the pregnancy. And, that's good. That's the way it should be. It turns out that COVID is not good on fetuses. Fetuses are targeted by COVID. And we've seen fetal developmental problems. We've seen premature births and even maternal death from COVID-19. And the problems with a pregnant woman and COVID disease far outweigh any concerns about, I just lost my slide again, far outweigh any concerns about getting the vaccine. So if you're pregnant, you should think about getting the vaccine because that's the only way to protect yourself from having trouble. And then there are the sort of farther out there wacky things that this is all some big scam or conspiracy, or Bill Gates is putting a chip in your neck and all that. I don't know. To me, it's very difficult to imagine a rational person believing this stuff because, if it had just started in the United States and, I could see where you would say, well, yeah, it's all a political deal here. But, every country in the world has experienced this. Every country in the world has had to react to it. Every country in the world has been concerned about it. So it's real. You'll hear a lot of things about how did this get started. And to me, that's it just really doesn't matter how it got started. The fact is that it's here and we have to deal with it. And then I've talked to people who said, well, I had COVID, so I don't need to worry about it. I'm not getting the vaccine because I already had the disease, and so I'm immune. And that's a reasonable argument too. But what the evidence shows is that if you get vaccinated, you are much less likely to have long haul symptoms, and you are much less likely to have trouble with any variant that comes along. The vaccines are not 100%, that's true. And we've seen that over time, some of the immunity has waned, and it may be, as I said, that another booster is going to be recommended at some point. But it's the best thing we have, and it works really well. They are very, very safe, and it's really the only responsible thing to do. Next slide. So when you're talking to somebody who is hesitant, and at this point, I think we're down to the last few that we're going to be able to convince. But I think belittling them or arguing with them is not productive. I think acknowledging their fears, because a lot of these fears really, there is a basis for. And even myself, when I first started out, I thought, man, they did develop this pretty quickly. And it wasn't until I investigated how they actually did it that those fears of mine were allayed. So acknowledging their fears and then sharing with people why you got vaccinated. And as I said, I did it not just for myself. I don't want it, but I didn't do it just for myself. I did it to protect other people in the community and to protect patients that I see. And then I think if you can find either in your staff or maybe in your community, reputable people, not necessarily medical people, but reputable people who got vaccinated, and just ask them if they'd be willing to talk to people and kind of share the reasons why they got the vaccination and share their experience with it. I think that a lot of this is just all based on trust. And I think, and this to me sounds like sort of what Sabrina was talking about. You just kind of wear people down. You kind of gently keep saying, we got the vaccine here today, and it would be a good thing if you got it, and you really ought to think about it. And if they refuse, well, next week you're right, you're still there, still saying, we've got the vaccine here, and this is nasty stuff. You really don't want to get this. So kind of gently coaxing people, I think, works much better. And you have to recognize there's some people who you're not going to convince, and especially if they have a political argument, it's probably not worth even getting into it. That's really not going to go anywhere, and I don't think you're going to convince those people. But acknowledging people's hesitancy, acknowledging their fears, and then kind of gently explaining why you weren't concerned about those and why you made your decision, and especially putting it in the context of you're doing it, to be a good citizen, you're doing it to be a good neighbor, you're doing it to protect your family, your friends, and the people that you come in contact with every day. Next slide. That might be it. Yeah, so that is it.
Well, thank you, Dr. Kunzweiler and Sabrina. Those were great presentations, a lot of food for thought. I just want to make a comment. There's a couple of comments in the chat box that I wanted to make sure that we acknowledge. Vanessa indicated in response to my question about hesitancy. She's from Hawaii, and she says that the staff there feel like 2 doses are enough and that the new variants are milder. And that was part of the reason for opting out of the booster. And then Lori makes a great comment in chat about the pneumococcal vaccines, the Hep B and the HPV and other great vaccines that have changed the impact of disease in recent history also. There's an evaluation link also that Mary posted for us in the chat box. So if you have a second to give us some feedback, we'd sure appreciate that. And then Lori commented that in Alaska, some of our Alaska Native communities feel experimented on. with vaccine, which has been difficult to respond to. She suspects that other states with native populations may have similar concerns. So those are really great, great observations and great points for sure.
Yeah, and I think that, feeling like you're being experimented on is very understandable in that population. And I think you just have to point out that, it's not just you. There are hundreds of millions of people worldwide now who've been vaccinated. And this is not experimental anymore. The experimenting phase is long gone. And this is being done to try and protect you and try and help you. And I've worked with Native communities here in Montana, and they, in my experience, they tend to have a pretty strong sense of community and a strong sense of honoring and protecting the elders. And I think that's kind of where you can go with that argument. This is really a bad thing, especially for older folks whose immune system might not be as good as it used to be. And this is one way you can really honor them and help protect them.
That's a great idea, great notion. Thank you. Well, everybody, we went a little bit over today, but it was great conversation. I appreciate you hanging in there and hanging on the line. We'll see you next week. If you think of anything you need from Mountain Pacific in the meantime, please don't hesitate to reach out. And in the meantime, take care and stay warm and well. Thank you again. Thanks,
Thank you.
Sabrina. Thank you, Dr. Kunzweiler.
Welcome. Thank you.
Thank you.